Welcome to ATCM, the Emergency Medicine channel. Today we are discussing about one of the most common inflammatory polyarthritis, that is rheumatoid arthritis. Rheumatoid arthritis is an inflammatory deforming polyarthritis. That means there is joint inflammation, there will be swelling, painful movements, difficulty in flexing the joints. Deforming means after some times of illness, the joint will develop deformity. Many other inflammatory arthritis will not produce deformity, like SLE will not produce deformity. So this is inflammatory, deforming and polyarthritis. Mainly multiple joints are involved, especially hand joints. It's very common in female patients, but it can occur in even male patients. Common age group is 30 to 50 years. The onset of disease after 50 years is very rare. 50% of the cases are associated with HLA-DR4. So these are the major features of rheumatoid arthritis. Now we'll go in detail about this inflammatory polyarthritis. It is a problem in the synovial joint. They produce immune complexes at articular and extra-articular sites and produces chronic inflammation, widespread persistent synovitis, and proliferation of synovium into folds. Synovium become thickened, hyperplastic, then it spread into the joint margins and cartilages. So inflammation spreads like anything inside the joint and outside the joint. It can produce inflammation. Inflammation of the synovium after sometimes can produce damage to the cartilage. It can even spread to the bone also. So inflammation starts inside the synovial joint, then it destroys the cartilage, then it also spread to the bone spaces also. That is a problem in rheumatoid arthritis. Now we can see the clinical features of RA. So there are some main features. Morning stiffness is one of the most important clinical feature of rheumatoid arthritis. Many other joint diseases also can have morning stiffness. So difficulty in flexing and extending the joints, that is a classical, especially in the hand joints. That is more than 1 hour. Early morning stiffness which lasts more than 1 hour is a classical finding. Arthritis of 3 joint areas. That means inflammation. It should be painful to touch. There will be swelling. There may be redness. So inflammation of joint more than 3 joint areas. Arthritis of hand joints, especially the small joints in the hand, like wrist joint, MCP and proximal interphalangeal joint. Symmetrical arthritis, this is very classical. Many other arthritis can present with unilateral arthritis, but rheumatoid arthritis classically present with symmetrical hand joint involvement. Rheumatoid nodules can be seen in many patients, subcutaneous nodules on the extensor surfaces of the, especially on the hand and wrist and all. Radiological changes we will discuss afterwards. Rheumatoid factor can be positive. So this is a classification criteria for rheumatoid arthritis. A score more than 6 is definite for RA. But remember, polyarthritis, which dominantly involving the small joints of the hand, bilateral, symmetrical, that is classically rheumatoid arthritis. After some times without treatment, patient can develop deformity. This is rheumatoid arthritis. Now arthritis is especially on the small joints, but there are different types of presentation for arthritis. 70% of the cases are slowly progressive, 15% are rapidly progressing, 10% can present with monoarthritis. This is very rare, especially in the knee and shoulder joints. Palindromic rheumatism, so short-lived episodes of acute monoarthritis which resolves completely. So that may not classically present with rheumatoid arthritis features. Monoarthritis can also occur in some patients. Seronegative rheumatoid arthritis means rheumatoid factor may be negative. So that is classified as seronegative. Serological evidence is not there, but clinically it is rheumatoid arthritis. The joint involved are classically metacarpophalangeal joints, proximal interphalangeal joint. This is a classical joint which is involved in the rheumatoid arthritis. Then wrist, elbows, knees, ankles and shoulders. Hip and spine are not usually involved. Hip and spine are usually involved in ankylosing spondylitis. So they are not involved in rheumatoid arthritis. Seronegative limited synovitis, less symmetrical, wrist more than fingers, better long-term prognosis. That is seronegative synovitis. Spine, cervical spine involvement can be there in some patients, but not in all. Other joints like temporomandibular joint, this is one classical area which patient can have pain and difficulty in moving the temporomandibular joint, headache, cervical pain, all these things can be there. Then acromioclavicular, sternoclavicular, cricoarytenoid joint, all can be involved in rheumatoid arthritis, but classically it is in the hand joints, small joints of the hand, symmetrical polyarthritis, deforming arthritis. Now you can see here some deformities on the hand, bottom-ear deformity, ulnar deviation of the metacarpophalangeal joint, swan neck deformity of the fingers. These are some of the deformities you can see on the hand of the patient. This is a classical type of joint deformity if the patient is not receiving any treatment for rheumatoid arthritis. Now extra-articular involvement, one of the most classical example is subcutaneous nodules or rheumatoid nodules. This can be there on the extensor aspects of the limb. Lung pleural effusion, ILD, Kaplan syndrome, that is pneumoconiosis, lung nodules, all can be there. Blood vessels, patient can have vasculitis like stroke or myocardial infarction or superficial arterial thrombosis, all can occur. Leg ulcers are many patients present with leg ulcers. There is a non-healing ulcers can be seen in many patients with rheumatoid arthritis. Heart, you can get Raynaud syndrome, that is peripheral arterial occlusions, pericarditis, myocarditis, endocarditis, pericardial effusion, conduction defects, aortic regurgitation, coronary artery disease. Nervous system, atlantoaxial subluxation. This is very common in patients who is having rheumatoid arthritis. Other areas of the spine is not that involved. Peripheral neuropathy, mononeuritis multiplex, entrapment neuropathy like carpal tunnel syndrome and all. Eyes, scleritis, episcleritis, scleromalacia, keratoconjunctivitis sicca, that is dry eyes. Renal nephrotic syndrome is very common if the patient is not receiving any treatment. Secondary amyloidosis can produce proteinuria and nephrotic syndrome. Blood Felty syndrome, that is splenomegaly, neutropenia in a patient with rheumatoid arthritis. Anemia can occur in many patients. High platelet count is due to chronic inflammation. Pancytopenia due to hypersplenism. These are some of the common presentation that patient can have. In that, rheumatoid nodule is very common. Other things are not that common, but still we see patients who are not receiving proper treatment. We can see all these complications. Now, if we have a patient with suspected rheumatoid arthritis, we send two important investigations. One is rheumatoid factor and anti-cyclical citrullinated peptide antibodies. Rheumatoid factor has got a prognostic value also. It can present in 70% of the cases. It is negative in 30% of the cases. We can call them as seronegative arthritis. And anti-CCP is another important antibody. Specificity is 90, sensitivity is 60%. So that is more specific and sensitive than rheumatoid factor. But if we have a patient who is having rheumatoid arthritis and rheumatoid factor is negative, we can go for anti-cyclical citrullinated antibodies. If that is positive, then diagnosis is confirmed. Some patients rheumatoid factor may be negative and their anti-cyclical citrullinated peptide can be positive. This is one of the earliest marker of rheumatoid arthritis. Even before starting the arthritis, this can be positive in some patients. Now, the major investigation other than the antibodies what we discussed is X-rays. X-ray hand or joint can be taken. In that many findings you can see soft tissue swelling, periarticular osteopenia, bone erosions, articular or cartilage erosion, destruction, joint space narrowing. So many things can happen in the joints. If we want to know what is the type of inflammation, we can aspirate the fluid and see what is happening in the fluid. So there will be culture negative, but the cells are high. So that can be aspirated and find out that there is an inflammatory joint disorder in the joint. Diagnosis of rheumatoid arthritis is mainly clinical. It is bilateral, symmetrical, small joint involvement, and they slowly produce deformity. Now SLE and all, if you take, they can have bilateral joint involvement, but they are not producing deformity. And sacroiliitis, peripheral joints are not involved, mainly in the axial joints are involved. If peripheral joints are involved, they are asymmetrical. And gout, if you take, it is a monoarticular involvement. So once you make a clinical diagnosis, then only we should send rheumatoid factor. Otherwise, sometimes in a patient who is having without arthritis also, rheumatoid factor can be positive. So we should never send rheumatoid factor in a patient who is not having typical clinical picture of rheumatoid arthritis. Now we can see what are the treatment available for rheumatoid arthritis. Once we diagnose the case, we have to give symptom control. First thing to do is symptom control. The major drugs are, we can give either paracetamol 1 gram TID or any NSAID can be given. So COX-1 or COX-2 inhibitor can be given. So that can give anti-inflammatory effect, pain relief, all these things. We should always give proton pump inhibitors along with these NSAIDs. All patients can be given, in elderly patients can be given low dose aspirin also, because some patients can develop arterial involvement and stroke, myocardial infarction and all. So low dose aspirin also may be beneficial. Steroids are actually used as bridge therapy in between the drugs, that is DMRs. We will discuss that, between the anti-inflammatory drugs to DMRs, because DMRs take some time to act. In between, we can use steroids as a bridge therapy. Normally, we can give Visalon, that is prednisolone, 0.5 to 1 milligram per kg body weight, then slowly taper down the dose. So when we are treating the patients with steroids, we have to give proton pump inhibitors, calcium supplements, vitamin D supplements, all these things should be given. We have to check the sugar, we have to see what is the blood pressure, whether the pressure is increasing or not. Now intra-articular injections of triamcinolone, there is a type of long-acting steroid that also can be tried in more symptomatic joints. So steroids are used as bridge therapy. We can use prednisolone or any other equivalent steroid, 0.5 to 1 milligram per kg body weight initially, then slowly taper down the dose. Now another type of drug category, that is DMARDs, disease modifying anti-rheumatoid drugs. These drugs are used in many other rheumatological diseases. The most commonly used drug is methotrexate. This is an anti-cancer drug, but we use methotrexate in rheumatoid arthritis. The usual dose is 7.5 milligram per week, but initially we will have to give 30 milligram or 25 milligram as an initial dose per week. Suppose we are giving on Monday, next Monday it should be given, repeat dose should be given. After the next week we can give one more, like that it should be continued. Folic acid also should be given, not on the day of methotrexate, you can give all other days. Folic acid must be given. Many patients may miss folic acid when they are taking methotrexate, that may produce bone marrow suppression and produce severe anemia or neutropenia and all. When we are giving methotrexate, we have to see liver function test, chest x-rays, or auscultate the chest for any fibrotic changes. Very rarely occurring complication of methotrexate is lung fibrosis. Even rheumatoid arthritis itself can produce lung fibrosis. So always when we are treating the patient with methotrexate, at least every 6 months take a chest x-ray or auscultate properly to get a lung crepitations. TB is also common in this type of patient because they have a disease which can reduce the immunity. They have a drug, methotrexate, which can also reduce the immunity. So TB is common in this type of patients. So TB should be ruled out every time when the patient visits to hospital. Hydroxychloroquine is another drug which can be given in this type of patients, but a periodic eye checkup is very, very important to avoid the retinal pigmentation. Sulfasalazine 500 mg per day or increase to 500 mg 3 times daily or 1 gram 3 times daily can be given. Blood count should be monitored. Leflunomide is another drug, 100 milligram per day, 3 days, then 10 to 20 milligram per day. We should follow blood counts and lefty. So various conditions we can select different type of drugs, but the classical drug which is used in rheumatoid arthritis is always methotrexate. We no need to worry about the side effects of methotrexate. Very rarely it can produce side effects. We can start 25 milligram for an adult patient every Monday or Tuesday, whichever day you like. Then other days we have to give folic acid and slowly taper down. 25 milligram we are starting. After 2-3 weeks, if the patient improves, it can reduce to 20 milligram, 15 milligram, 10 milligram, but minimal dose is 7.5 milligram per week. That should be continued. Other drugs also can be tapered down. If the patient is symptomatically improving, we can taper down the therapy. If the patient is not improving, add another drug. For mild disease and all, hydroxychloroquine may be enough. So this is a pathway to treat the rheumatoid arthritis. So clinical history is very important. Then do rheumatoid factor or anti-cyclical citrullinated peptide. Take an X-ray. All these things are required for documentation. Then start the treatment according to this type of protocols. But most of the doctors prefer to start methotrexate. Now another type of drug, another class of drug is biological DMRs. So biological DMRs, there are many types of biological DMRs are available. They are tumor necrosis factor antagonist, that is etanercept. So like that many other drugs are there. So TNF antagonist, another TNF antagonist is infliximab, adalimumab, interleukin 1 inhibitor, anakinra. So many drugs are available in this class. So that also can be given either as a salvage therapy immediately after you diagnose. If the patient is having severe symptoms, for immediate action we can give biological drugs like this and slowly taper down to another drug like what we discussed previously, like methotrexate or hydroxychloroquine. Or this drug can be repeated in a different time. The dose can be repeated. So these drugs can be given in patients with severe symptoms initially itself, or if the patient does not improve with routine DMRs initially, we can switch to these drugs. Now different types, we'll just go through these drugs. They are anti-TNF alpha agents, etanercept, 25 mg subcutaneously twice week or 50 mg 1 per week should be given. Another drug is rituximab, IV infusion 1000 mg on days 1 and 15 in combination with methotrexate. Subsequent courses may be administered every 24 weeks. Another drug is infliximab, that can be given 3 mg per kg at 0, 2 and 6 weeks, then every 8 weeks. Thereafter 3 to 10 mg per kg body weight repeated 4 to 8 weeks interval. Adalimumab, a recombinant monoclonal antibody that binds TNF receptor sites, that should be given as a dose of 40 mg subcutaneously every alternate week. Another important class is anti-interleukin 1, that is anakinra. The dose is subcutaneous 100 mg once daily, administered at approximately the same time each day. Anti-interleukin 6 receptor monoclonal antibodies, tocilizumab. The dose is initial 4 mg per kg every 4 weeks, may be increased to 8 mg per kg depending on the response. Now there are different types of drugs. This is abatacept, that dose is IV dosage, that depends on the weight. So can be given less than 60 kg 500 mg, 60 to 100 kg 750 mg, more than 100 kg 1000 mg. Like that dose should be done. And one important factor in rheumatoid arthritis, that's a deforming arthritis, we have to treat with NSAIDs, steroids, DMRs or biological DMRs. But once the deformity occurs without physiotherapy, it may not improve. There are different modalities of physiotherapy. Once the patient is pain free, we have to immediately start physiotherapy, otherwise patient will develop slowly contractures and deformity. So physiotherapy has got a major role in treatment of rheumatoid arthritis. So we have discussed one of the most common inflammatory polyarthritis, that is rheumatoid arthritis. There are different classes of DMARDs available. Disease modifying anti-rheumatoid drugs are available. When we use these drugs, side effects are very, very important. We should know about side effects and its treatment. Thank you.